Welcome back to the School of Privatization. Today our lesson will continue covering private surgical and diagnostic clinics. The Ontario government has proposed 2 regulations to move public hospital surgical and diagnostic work to independent health facilities. The major growth of private for-profit surgical and diagnostic clinics in Canada has occurred in the last 5 years. Private surgical and diagnostic clinics start opening in the provinces with the largest potential markets: Ontario, Alberta, British Columbia, and Quebec. The majority of private for-profit clinics are maximizing their profits by charging public plans and charging patients extra fees or through third-party insurance as well. The evidence shows that for-profit delivery erodes the public health system by taking financial and human resources out of the public system and by promoting two-tier health care. The federal government is not enforcing the Canada Health Act to protect patients from increasingly aggressive attempts to dismantle equal access to health care. This proposal opens the door to American-style private hospitals and raises several major problems. Private specialty hospitals are found in the United States healthcare system. But even in that privatized system, full-service hospitals have assailed specialty hospitals for cherry-picking the most profitable procedures from general hospitals. The growth of the private healthcare industry in the United States has resulted in a major problem of fraudulent billings to public health plans, insurance companies, and patients. Though regulatory regimes are in their infancy across Canada, we have already seen the introduction of private healthcare fraud. In the United States, specialty hospitals are often owned and run by doctors, and there is concern that the doctors have a financial incentive in sending patients to their own facilities, even when those patients might be better off having their surgery in regular hospitals. The problem with physician-owned specialty hospitals is that decision-making is more likely to be driven by financial interest rather than patient interest. The evidence and case studies show that for-profit status of the clinics had no relation to the repeated claims of reducing wait times. In fact, these case studies show that the for-profit clinics were less efficient than public clinics and required more money to provide treatment. The for-profit clinics not only cost more in terms of financial resources, but also diminished capacity in nearby public non-profit hospitals and also provided care only to non-complex lighter care patients. The public hospitals will be left with patients with complex conditions. Always in private delivery of healthcare, be it in the United Kingdom or the United States, the private sector is interested in speed, volume, and profit. In contrast with public hospitals, private specialty hospitals will be unable to handle many emergencies and will simply call emergency medical services. The difference is a community hospital plans for the unpredictable. Ultimately, the experience with the for-profit MRI and CT clinics in Ontario yields direct evidence that the clinics increased wait times in non-profit hospitals to sell services for profit, regardless of medical need. The underlying problem is that public disclosure runs contrary to the interests of private providers, not just in the clinic business, but everywhere privatization appears in healthcare. It reveals secrets to competitors and problems to the public. Both threaten the ability of investors to remain in business, making profits. The contracts with private surgical and diagnostic clinics were shielded by commercial secrecy and have never been revealed to the public, though they were paid with public funds. In Ontario, private clinics are self-policing, unlike hospitals, which are accredited and regulated. Studies show higher death rates at private clinics. And in the United Kingdom, the costs of the private clinics have been much higher than originally forecast. The impacts of the consolidation of these procedures in private hands will be the gradual closure of smaller community hospitals, higher costs, user fees, and higher death rates. Hospitals are the cornerstone of the Medicare system in Canada, and this policy weakens them substantially. A similar policy has plunged many hospitals in United Kingdom into bankruptcy. Billing problems are also evident in Quebec. In early 2013, the Quebec Health Minister decided not to renew the contract with Rockland MD, the private hospital that has done about 9,000 publicly funded surgeries since 2008 in Quebec. The contract expires September 2014. Rockland MD claims to be able to perform a broad range of day surgeries, from the simplest to the most complex, in various specialties and within very short times. The public health insurer found that Rockland MD was charging people illegal facility fees, a charge often leveled against private clinics. Rockland MD disputes this and is resisting attempts to recover the money. In February 2013, the matter was headed for the courts. Quebec plans to bring all the surgeries back into the public system. The Ontario Health Coalition published a report based on interviews with private clinics which revealed widespread extra billing by existing private clinics. Indeed, the Ottawa Citizen recently revealed extra fees billed to the public at a private endoscopy clinic. The Ottawa Hospital closed its endoscopy clinic at its Riverside campus earlier in 2013, effectively turning the work over to private, for-profit clinics. But patients at two private endoscopy clinics are facing demands for user fees of $80. The owners claim they are underfunded. Please get involved and support the Ontario Health Coalition in the battle against private clinics. Surgical and diagnostic services belong to community hospitals with highly controlled standards, proper policies and procedures, properly trained staff and the ability to deal with emergency situations. Community hospital plans for the unpredictable. Ontario Council of Hospital Unions.